Hello, and welcome to the inaugural episode of the Atherosclerosis podcast, a series hosted by the EAS Young Fellows. My name is Antoine Rimbert from l'Institut du Thorax in Nantes, France, and I'll be your host for today's episode. We're excited to launch this series of experts interviews with Professor Tybjærg-Hansen from Copenhagen, Denmark. This conversation was recorded during the European Lipoprotein Club meeting in Tutzing, Germany. Okay, so Professor Tybjærg-Hansen, just a couple of words on your career, brilliant career. You're the chief physician at the Department of Clinical Biochemistry, section of molecular genetics at the Copenhagen University Hospital. You've been pioneering the field in lipid-related cardiovascular diseases. You're executive editor of the European Heart Journal. And a member of the steering committee of the Copenhagen City Heart Study and Copenhagen General Population Study. You are also the first woman who received the NHCOF prize a couple of years ago in recognition of your research in 2018, actually. So hello, Professor Tybjærg-Hansen. On behalf of the EAS, I'd like to thank you for accepting our invitation. In this interview or podcast, we want our listeners to get to know more about you and your research and your career. So could you please introduce yourself to our listeners?
So as Antoine touched upon, I am Tybjærg-Hansen. I'm a professor of clinical biochemistry at the University of Copenhagen and a chief physician at the Department of Clinical Biochemistry at Copenhagen University Hospital. And what I do for a living there is actually diagnostics of inherited heart disease. Among these diagnostics of dyslipidemias of any kind, but of course mainly FH. But also other heart diseases.
Okay, thank you. And before asking your academic-related questions, we'd like to ask you some personal questions so that our listeners can get to know you better. Could you please describe to us what a typical day in your life is?
I don't think there are any really typical days. They vary a lot, but generally they start with me getting up not too early if I can avoid it. And then I bike to work. I've always done that, so I bike about 8 kilometers, something like that, to work every day, rain or shine. And then there'll usually be some meetings, of course, department meetings, some days, and then I'll have meetings with the people at the department, the young people, right, for discussing research projects, and I'll usually have some papers that I'm working on too. And then I have quite a large clinical duty. I don't see patients, but I see patients as blood samples, and I actually countersign all the descriptions of what we find in these patients with inherited heart disease, and that takes quite a long time also because the number of patients that we see actually has skyrocketed. So we do a lot of genetic tests. But it's fun. I love it.
Yeah, sounds like easy days, right?
Yeah.
So any time left for hobbies, or for what are you doing in your free time?
My work is my hobby, right? I think science is, I'm sure it's a way of life, right, in many aspects. But if you're asking what I like art. I also like music. I mean, I used to be a ballet dancer, actually. So I obviously like ballet.
Okay. And you play the music a bit?
I don't play music. I mean, I used to play piano. I'm not good at that, but I sing. I like to sing, actually.
Okay.
I won't sing for you, I promise.
Okay, so you found your balance between your free time and
but
work.
I love my work. I particularly like the research, of course.
Okay, okay. On a personal point of view, what would be your main goals in the coming years?
My main goals. I have a couple of things. I'm very interested in that have nothing to do with lipids, but maybe they started with lipids or apolipoproteins, and I'd like to be able to work more with that and to discover something there, which I think would be possible for us, because I think it's a field that's driven by the drug companies, but where the research is really not there, right? So I hope we can contribute there, and I can talk a lot about that, right? I don't think you want to hear that.
No, but thank you. So back to your career and really, brilliant career, I must say. Could you tell us about your academic journey? How, like, for example, what you've been studying, and what were some of your key decisions in your career to get you to this point?
Yeah, not a very organized career, no career development here, really. So I started as a clinician, and I like patients. I like seeing patients, right? But you can't do both, actually. And of course, I did my basic training in Copenhagen at Copenhagen University and became an MD, and then my basic training as a doctor. Mostly in Copenhagen also. And then I got really interested. I guess I also was, under my studies, interested in genetics. But I got really interested in genetics of atherosclerosis, actually. And I applied for a small grant to work at something called Kheirkhah Research Lab, which was then under Novo Nordisk. And the grant was, this was where the funny thing about my first talk came in, was about the insulin gene, right? And copy number variant in the insulin gene and risk of diabetes. And I got the position, and I quickly found out that it was a lot of nonsense, probably. And but then I started reading about atherosclerosis and genetics, and I read some very interesting papers about from Steve Humphries, actually. And Steve Humphries was actually the first person already in the late 80s to say that common variants, the combination of common variants, what we call polygenic risk score now, would be very important for disease. And people thought he was nuts, right? But he was right. Yeah. And so I think I called him or wrote to him and asked him if I could come and see him, and he said yes. And I also called Jan Breslow, who was an American guy who was a professor at Rockefeller University then, and it was because I was thinking about, could I go to one of these places? And I ended up going to Steve's lab, and I was there for 3 years, I guess, in London, and it was a fantastic time. I learned a lot, and it was very cosmopolitan, like London is, and there were all these big wigs that passed through the lab, right? Yeah. And there I was actually working on common variants in ApoA1 and ApoB and ApoC. ApoA5, and then I got the only ApoB variant that is associated with FH is 3527, right? And that was discovered in the States, and I quickly thought, I want to see what this looks like clinically. And I had some samples, right, from Copenhagen, and I did southern blots, to see what the genotype was, and it took forever. So I managed to do southern blots on probably 450 patients or something like that. And I could describe the clinical phenotype. So that was one of the really big things in my career and really got me going, right? And I mean, this is still the only mutation in ApoB that's common and associated with FH, and and it's any lab that does genetics of FH actually looks at that mutation. Sure. So that was big. It's a common mutation in Denmark, by the way, relatively common. And then what? Then I had to go back. That was difficult. It was difficult to go back because Denmark is a small country, and really people couldn't care less about whether you had been abroad. That didn't mean anything at all, right? And it certainly didn't mean anything if you were a woman at that time, and I had a hard time. Really hard. Okay. Yeah, really hard time. I mean, I don't think I should go into details, just it was another time, right? And it was difficult for a woman to have a career, not from my husband supported me, right? But there was certainly resistance among especially older men at that time. So very difficult, but I always thrived with somebody who tried to keep me down, and that doesn't work on me, right? So I fought for it, and I had the Copenhagen City Heart Study at the third examination. I had gotten involved in that and suggested that we should isolate DNA from 10,000 individuals. That was a big study at that time, right? And
what was the year at that time?
That was 1991 or something, 1990, something like that.
That was really pioneering the field, because it was really precursor idea at the time.
And so we had the genetics, but we also had all the biochemistry, and we had lung function tests, and they are very well examined. And of course, we had the longitudinal aspect also from that study. And then that, of course, became too small, and I, together with my husband, but it was mainly him that drove that, because his department was willing to pay, right? Mine was not willing to pay. So he started, together with me, the Copenhagen General Population Study, which of course now is a big study, but there are bigger studies than that, as you know, UK Biobank and so on. But and we started with association studies, and then we went on to more in the Mendelian randomization area, and then to other more complicated ways of looking at Mendelian randomization. Yeah,
very nice. So you talked about the good decision to go to Steve Humphreys. So looking back at those achievements, so you had many in your careers. What's the most important for you in your career, the achievement?
So one is ApoB 3527, the description of that, and the other is the discovery that HDL was not a causal factor for cardiovascular risk, and that made me persona non grata actually in the society. But it changed the field, right? But people thought I was mad, basically.
Apparently you were right.
And then the next, of course, was ApoC3 inhibition, right? Which in a way, was like PCSK9. But of course, we still need to see that the inhibitors will actually reduce risk, right? We still don't know that, but we'll see that, and I certainly hope it will be positive. And then, of course, I hope that some of my other ideas will also do something. Yeah, we actually have had a study in 2013 which sort of started this, and nobody really understood it. And that's now a very cited paper because times changed, right? So that's funny.
You said your career was not really planned, right?
No, not at all.
So for the youngs who are listening us, any advice for their career as young scientists starting in the field, maybe as a woman specifically, what would be your advice to them?
But I think for women it has changed a lot now, right? I mean, there's pretty good equality between men and women now, but there wasn't then. I mean, there are a lot of men who will say there was, but there certainly wasn't. It was much more difficult for women to become professor. I mean, my then boss, he said, not all people become professors. And I thought, we'll see about that, my dear.
Okay.
So the advice would be, the best advice is find a really good supervisor.
Yeah. A good mentor.
Yeah, a good mentor.
Okay.
Someone who publishes reasonably good, right? It doesn't have to be Nature and Science or New England Journal of Medicine, all of it, but somebody who publishes good papers and regularly publishes and will take care of you, will really mentor you. I mean, that's something we always did. We mentored people on a daily basis. I always have my door open and people can come in almost any time, right, and talk to me.
Yeah.
And I think that was important for me. And I was lucky, I guess. But you have to look into that, right? You really have to, as a young person, look at these things, right? So you don't get, flabbergasted by somebody who says they have a fantastic project for you. Yeah, maybe the project is fantastic, but if the group is not good, nothing will come out of it.
Okay. Yeah, good. We talked about your first talk a couple of minutes ago, before this interview.
Horrible.
It was fun,
I was so
story.
nervous.
But it will be in another podcast. And do you still feel, I mean, you've been presenting in huge audiences, like thousands of people in the room. Do you still feel nervousness?
Yeah, I feel... slightly nervous. I think you have to be slightly nervous. I don't feel, nervous so that I can't function like I did when I was young not for many years, but for some years, But I still feel tense. I don't think you can do it really good if you're not tense, right? You have to have your adrenaline going, right?
But it changes over time.
Yeah, it changes. It gets better, right? But it doesn't disappear. I don't think it should disappear. I think if it disappears, you should stop.
Somehow.
Yeah.
Okay. What about your scientific projects nowadays, when compared to what you've been doing in the last decades in your research?
So like I said, I got interested in other aspects of apolipoproteins by chance. I can tell you what it is. It's amyloidosis, right? Because many of the apolipoproteins are amyloidogenic. And I didn't know that actually at the time. I was working with APOA1 and I found a variant together. I had some help from people who were good at in vitro studies. And we could see that this variant in APOA1 was not an LCAT deficiency variant or anything of these other deficiencies. It was an amyloidosis variant actually. And it's A1 amyloidosis is rare. But then I started looking into what were these diseases, right? And now, of course, there are two relatively common forms of amyloidosis, or the most common forms. One is AL amyloidosis, which is light chain amyloidosis. That's a hematological disease. But the other is transthyretin amyloidosis, and that's an immensely interesting disease. And from a cardiovascular point of view, probably also a relatively common disease in the elderly.
Okay.
And there's now tafamidis available for treatment. It works by stabilizing the tetramer. It's a tetramer. Okay. And there are a lot of other drugs under development. So that's an interesting field, but like I said, very driven by the drug industry. So there's not so much what I would call real research going on there. So I think I have some ideas that I think are quite logical, of course. But others don't really see it that way.
But you're going to follow the same line of thoughts, right?
Yeah.
Regarding the okay.
Yeah.
And you have all these amyloidosis recorded in your studies in Copenhagen City Heart Studies, maybe not, but general population also.
Yeah, but the thing is that until recently, the diagnosis, it has not been diagnosed, right? Yeah. Because these patients, when they show up as heart failure patients, okay, or patients with restrictive cardiomyopathy. And then they are already at a very late stage in their disease. So if they're not treated, they die within 5 years or something like that. So my idea is, of course, that I want to be able to diagnose them 10 years before or more, because we know that it starts already long before.
It's like atherosclerosis.
Yeah, it's like atherosclerosis, right? Okay. I just think it's very intriguing, right? I like these things that are impossible to solve.
Okay. And what are the ideas to translate these findings, epidemiological, genetically based studies, and how you're going to translate it? Because now you don't know much people in the field, I guess.
No, that's
a couple of years back, right?
Yeah.
So what is your strategy to translate what are you going to find and make sense out of it?
But I think I have an idea of what it's about, right? So I'm of course going to work in that direction. Actually, it's a disease, right, where there are mutations in the gene, but that's a very rare cause of the disease. So that's really not, from a population point of view, important, right? The important is the other part, which is wild type disease. It's basically wild type. The wild type protein becomes unstable, and then it fibrillates, and then it comes down into the intracellular space in the organs and ruins the organs, right? And the heart is very susceptible to this. Okay. And so you want to be able to measure this destabilization, basically. Okay. And I'm not sure I know how to do it, but I hope I can get some people to help me, right? Sure. Who know more about proteins than me, right? Yeah.
Good. So, you work on populations, and we always, these days, we talk about personalized medicine, polygenic risk scores, and who we are going to treat and how. And what's your expert vision on these?
I can say a little about polygenic risk scores, right, and how you're going to use that, and artificial intelligence probably also. Mm-hmm. So I think it's pretty clear. I follow this a little on the side, right? Also because we will be using polygenic risk scores. We have to, right? Because the people who are our customers, they are screaming for that, right? But that's also driven by technology, right? Because you can do it, but you don't know how to translate it, basically. You don't know how are you going to convey to the patient that he is in the upper 10% of a polygenic risk score. What's the background population? What is my risk? Yeah. So all these things have to be thought through, but I think where it'll be useful is, added to some of our normal risk prediction algorithms, for example, SCORE2, as we use in Europe, right? Mm-hmm. But also, and that has been shown, right? Also, the other risk estimate is QRisk3 and the American one, which I can never remember the name of. What is it called? AHA-ACC something.
From the guidelines, the one we all read.
But I mean, and then of course the development of AI will be enormously interesting to follow, right? And I'm sure for some things it'll really be valuable in hospitals for diagnosing, right? But of course that also has to be trimmed, right? So you are pretty sure what you are doing, right? Yeah. But that'll be helpful. It'll also save a lot of time.
And also for the trajectory, I think, in the next future. But at the end of the day, are we going to treat patients differently based on this polygenic risk score in our field? I mean, lipid field and atherosclerosis. That's something I
we don't really know, right? Because we don't, and one of the reasons we don't, I mean, it'll not be a lipid risk score. It'll be a cardiovascular risk score, probably, right? But I mean, we don't know what we are treating, right? Because we don't know what half of the variants do, or do they do anything, right? Or what are the causative variants? We don't know that either, right? Yeah,
no,
but I think it's really driven by the companies that make these risk scores, because what people do is they buy a risk score from somebody, right, somewhere, and they are told that they are in the 10th percentile and their risk is such and such, but they can't use that for anything. Then they go to their poor GP and say, I have this risk score, what do I do about that, right? And they will be scratching their heads. Yeah. So we have to find a way of also, telling the doctors who take care of patients what it is, right? I mean, what is the score? Also, how is it actionable? What does it mean?
Mm-hmm. Yeah, I agree. So you are executive editor of the European Heart Journal. We also talked about it a bit earlier today. We'd like you to ask you a related question to this editorial part of your work. Some researchers believe that it's almost impossible to get their work published in these high impact journals, such as European Heart Journal or others, because they come from countries or institutes that are not really renowned. What do you think of this statement? And is it really a problem?
I don't think that's a real problem. Actually, I think it's probably perhaps more the other way around, right? That some people come from a very renowned institution, right? And maybe somebody will think that, this is a renowned institution, this must be good. I mean, there's some right in that, but that said, it doesn't happen that way. I mean, there are also lots of things from very renowned places that get turned down, actually. So, I mean, I think you should just, you should think about whether it's a good paper, right? Is it a good question? Is it timely? Is it well done, and is it clinically relevant? That's also a good thing if it's a clinical journal, right? It's different if it's another kind of journal, of course. And if you think that, you can try, right? And the whole review process in European Heart Journal is very, very fair, I think, because it's there are many people involved, right? And it's very transparent, actually. Also.
Yeah, I remember a couple of years ago, there were some discussions to ask for reviewing, to make submission anonymous also.
Yeah.
Is it something which is considered in high-impact journals?
Anonymous submission,
talked about.
I don't think we have discussed that much, but it's not a bad idea, right? No.
Okay.
Yeah.
Oh, thank you very much. So we are close to the end of this interview. We, as I said, I think the young people are listening. We wanted to know: are there any positions or skills you are looking to recruit in your labs, and do you have any positions available nowadays? And which kind of profile are you recruiting these days?
I mean, I have MDs, but I also have pharmacists actually, and a molecular biologist also. He's also a pharmacist originally, but he is working as a molecular biologist. And I mean, with what I do, it's nice if you understand a little about disease, right? Otherwise, it becomes very difficult. of course, you never have a ton of money, right, to pay people for, but we're certainly looking for PhD students who would like to work, PhD students or postdocs who would like to work in this new field that we are trying to develop. And so it depends. And of course, it's nice if people can bring some money, but you never know what happens. Yeah.
Better ask for the most.
And the group is really nice. The people are really nice in our small section there,
Mm-hmm.
right? I mean,
how big is your group now?
The group is relatively small. Well, it's about 6 people in the group of academics, right? But then, of course, the technicians also, right? Okay. So quite a few technicians, actually, because the clinical work requires that, basically. Okay. A lot of our work in the clinic is done by technicians, and I think they enjoy that. They are not... They can follow the samples through the whole
from A to
way,
Z
from A to Z, and they like that better than you do this and you do
it's
that. That's not very fun. Yeah, okay. Exactly. Okay. Yeah, and then there's a lot of collaboration between the groups in the department also, okay. And of course with the guys at Herlev Hospital, right? The other group that we work with. Yeah. Of course.
Okay, well, thank you very much, Professor Tybjærg-Hansen, for sharing and for your time and insights with us. Also, a big thank to all our listeners. This podcast is for you, and we need your feedback to tailor it to your interests. So please don't forget to leave us your impressions or suggest topics that you'd like to hear from us. Again, thank you so much, Anne and Professor Tybjærg-Hansen. Any final word for this interview or podcast?
Yeah, go for it. Science is fun.
Enjoy. Thank you very much.